It is my honor to introduce our next speaker. I got to tell you, during the pandemic, as you may remember, we had a couple of virtual conferences, right? Those were tough. Not nearly as much fun as we're having today. And I hope the people at home online are having some fun with us as well. But we decided one day that we were going to have a Ask the Expert session and ask Dr. Perlman to host this. And I was going to be the moderator. I was going to take the questions and I was just going to feed them to Dr. Perlman. And we started like 3 o'clock and they kept coming and they kept coming. And I kept firing questions. And the gambit of what it could have been, whatever the questions would be, right? Well, I was exhausted, right? And it was 15 minutes into this thing. And I'm like, how are we going to do another 45 minutes? Well, we did another 45 minutes, and I was whooped, because I didn't know what was going to happen. The next day, we did it again. I knew what was going to happen, and you still beat me up big time. So, very proud to introduce Dr. Perlman, who's a clinical professor at and the director of the Ataxia Clinic at the UCLA Medical Center in Los Angeles. It is a great honor to have you with us, Dr. Perlman. Please give a round of applause for Dr. Susan Perlman. Let me get this out of your way. How's that?
Thank you so much for inviting me to speak again this year. I think the last conference that I was at in person was Las Vegas. So I'm glad that we're restarting this. It's way better than Zoom. A lot of what I'm going to say over the next half hour or so, you're going to be very familiar with, because half of what I've learned about ataxia, treating ataxia, I've learned from my patients. So I think, you know, some of this stuff is going to be old news, but I think some of the things we're going to be presenting are going to be food for thought. And the first food for thought is, do I know how to work this remote? Let's see. No, that wasn't the right button. Had an interesting chat this morning in one of the Birds of a Feather about how our children are so much, more facile with electronics. So potentially someone will show me how to advance the slides. The green, I just pressed it, it didn't work. Okay. Do I have to point it somewhere? Perhaps at Dr. Nye? Oh, it worked. All right, we're good here. Disclaimer, obviously anything I say, certainly about treatment, you're going to have to discuss with your own physicians, that we're not supporting anything, we're not giving you medical advice here. Okay, and I think to really reinforce our need to have a public-private partnership in development of treatments for ataxia, we have to engage industry. Industry has to feel free to come to us. Researchers have to talk to clinicians. And I've been involved with several companies that are developing drugs in the ataxia pipeline. And I can only encourage them that even though these are orphan drugs for rare diseases, that they are extremely important because some of them will actually have broader application to other diseases. So a drug for mitochondrial energy production, which we've heard about from Reata for Friedreich's, and I'll touch on a little bit later, might have application in Parkinson's disease, where the mitochondria are innocent bystanders, might have application in other genetic disorders, where the mitochondria are not producing enough energy, again, innocent bystanders. So I think a lot of this research may start with a very rare disease, ataxia, but could be expanded to some of the other disorders that are much more prominent. So, things you don't want to hear from your doctor. You don't want to hear them say you have ataxia and there's nothing I can do. You don't want to hear them say, I don't know what you have and there's nothing I can do. I think we have a responsibility to play an active role in educating our doctors, keeping communication open, even as they try to connect us up with appropriate support organizations and research opportunities, we have to bring things to them as well. For sure, doctors have to know what we're doing. If you're taking a nutritional supplement, if you're doing a particular exercise, they need to know what you're doing to better interpret the symptoms that you're coming to him or her with, and what their interventions might interact with. So bring up what you've seen on the internet, bring up stuff that you've heard in discussion with other ataxia patients and families. Let's have an open discussion. And like I said, half of what I know is because I spent time during a visit going online, looking up this particular therapy the patient recommended that they were doing well with, and learning something myself. So things your doctor should do. Should obviously confirm your diagnosis. Is it really ataxia? Is it genetic or non-genetic? Discuss risks for other family members. I've had patients come to me who've met with genetic counselors, had detailed notes prepared by their outside physicians and genetic counselors, but they still had questions about the risk for this cousin or this particular relative. So be prepared to ask your doctor, and even if it's something you think you heard before, it doesn't hurt to hear it again. Certainly make sure your doctor knows about your psychosocial state, how are you coping with ataxia, what support networks you have, what disability needs you have. There are things that can be initiated that can improve quality of life hugely if they're done in a timely fashion. Obviously, we know that rehabilitation helps, physical therapy, occupational therapy, speech therapy. There are symptomatic medications, which we're going to talk more about. And there are disease-modifying treatments in the pipeline for all the ataxias. And most ataxia specialists are willing to consult with your local neurologist or local healthcare provider about specific questions that may not be worth a trip halfway across the country to an Ataxia Center, but now with telemedicine, it's a lot easier to connect up with the experts who are more than willing to provide additional thoughts. So this is like really small and blurry, but you'll have access to the slides later, I understand. So treatable ataxias. There are definitely causes of ataxia that are treatable right now, and they fall into toxic exposures. Obviously, you stop the toxic exposure, which includes alcohol excess, where some 30% of people who drink alcohol in excess will develop ataxia. Vitamin deficiencies, other nutritional issues, autoimmune problems, and I think one of the primary components of a workup for somebody with ataxia, even if there appears to be a family history, is to check out the immune system. Is your body making bad antibodies that could be attacking the cerebellum, either because of a hidden cancer that's triggering the immune system or because of a glitch in the immune system? And there are very good treatments to reduce those bad antibodies, block those bad antibodies, and allow the cerebellum to heal. Similarly, some of the other immune-mediated processes that aren't associated with an underlying cancer, gluten ataxia. It is well accepted that gluten-free diet is very helpful in that situation, and people with ataxia should be screened for gluten antibodies and gluten sensitivity. And there are other bad antibodies, GAD antibodies we may have heard about, that aren't necessarily associated with a hidden cancer, but can be treated with immune-blocking therapies, intravenous immunoglobulin, high-dose steroids. So, it's important for somebody who's been diagnosed with cerebellar ataxia without a clear family history to be worked up for all of the potential poisons, toxins, and acquired factors. So, there is one FDA-approved therapy for one of the common ataxias. And this is the Reata drug omaveloxolone, or Skyclarys, for Friedreich's ataxia. So if I had given this lecture a year ago, it would have been really short. There are no approved drugs. Well, now we have one, as indicated, and potentially it's going to be the first of many. There are no FDA-approved drugs for any other form of ataxia, and currently Skyclarys can't, or when it becomes available in May or June, can't be used off-label for other ataxias, even if its impact on the mitochondrial energy production might benefit another ataxia. It's still very much restricted to Friedreich's. And there are no FDA-approved treatments for the symptoms of ataxia. So everything that you might have been asked to take or have tried to help symptoms have been taken from other diseases where those drugs were developed. Amantadine, which for decades has been a popular anti-fatigue, anti-ataxia symptomatic medication, was originally developed as an anti-flu agent, was fortuitously found to help mobility in Parkinson's, and then that was taken into the ataxia community, and we've been working with it ever since, despite the fact that it causes pretty severe constipation, which may be a reason that people stop taking it. But it was harvested from other disorders, and I think there are other drugs that people are using that were developed for one indication but are found now to be helpful for ataxia. So this is the Friedreich's ataxia pipeline. I think you've seen that. One drug has crossed the finish line. There are others close behind it. This is the information about obtaining Skyclarys, how to get a prescription. The prescription blank is indicated on the right there. There's a second page which asks for patient signatures to be contacted by Reata after they start taking the drug. And I presume that's to do what's called a post-marketing study to find out over the long haul how the general Friedreich's population does with this agent. They have a terrific website for doctors to access, for patients and caregivers to access. You can download the prescription. It doesn't have to be an ataxia expert who makes the prescription. Your local healthcare provider can download it and submit the prescription. The first steps, submitting the prescription, going to your insurance company to get authorization, which, for any orphan drug for a rare disease that's expensive, getting the insurance companies to pay for it can be a challenge. Since the announcement was made that the FDA approved it, my office has sent out 30 prescriptions for people that either were coming in for visits or who contacted me, people that I had seen recently who said, I want to try this drug. 2 people with commercial insurance got authorized right away. And the prescription is in, and when it can be sent out in May or June, they'll be able to start it. One person got a non-authorization message saying, this drug isn't FDA approved and we won't authorize it. And I'm thinking, what planet are these people on? Everybody knows about Skyclarys. So, and then, the others were still getting feedback, but people who their primary doctor, their primary neurologist doesn't get authorization, Reata has a team that will work next step with the insurance company to get authorization or to work out something so that cost is not a barrier. I mean, with any new drug, first drug for a rare disease, cost is going to be very high. And Reata doesn't want people to be, denied ability to try it because of cost. So that team seems to be working quite well. So this is the prescribing information. And it's interesting to see the first approved drug for any form of ataxia, what the FDA is doing with it, what regulations they're going to put on its use. Previously, when baclofen was first released as Leorosol, way back in the dark ages, it was approved for spinal cord injury, and maybe multiple sclerosis. And if you didn't have one of those 2 things, you couldn't get Leorosol. Very, very restrictive. Ampyra, dalfampridine, was approved for multiple sclerosis on the basis of improvement in walking. And we'll talk more about Ampyra in a little while. But they wanted documentation of the walking ability of the person getting the prescription. And I presume if you became non-ambulatory, the insurance company wouldn't authorize the prescription any further. So these basic restrictions for Skyclarys, pretty benign, and I think that reflects the fact that the FDA is more open now to orphan drugs for rare diseases. There's no contraindications listed. There's no black box warning. There's no training that the prescribing doctor has to have, the REMS strategy. There's some basic blood work that they recommend. There's a recommended dosage, but depending on side effects, the dosage could be lowered. And the adverse reactions, and you read the fine print about side effects from almost any drug, and it's like, ends in coma and death. So, for the most part, you don't want to read the fine print. But the common side effects, headachiness, GI upset, they indicate that there was a fairly high percentage, but none of the side effects were severe enough that people stopped taking the drug because they got headaches. So, I think overall, the FDA has been, convinced by the safety data and worked together with the company to make this as broadly available as possible. This is a graph of the definitive first trial, well, it was the MOXIe 2 trial, the first year, where the placebo group and the blue line with the treatment group were compared. The first 3 months, everybody got better. And I think in general, the placebo effect is there for almost anything that we try. The first time we try it, the first month or two we're on it, we feel better because we think it's doing something. The placebo effect is mediated by endorphins. So it's a real brain effect. It's not just, your brain is fooling you. There's a real effect which fatigues and dies out after 3 months. So after 3 months, that gray placebo line, people started getting worse again, and the blue line showed that people improved and stabilized at a level of improvement that they would have expected to decline over 2 years. So definitely suggestions of a symptomatic benefit and potentially a disease-modifying benefit. And when they went into the longer term, 2 years, 3 years, 4 years, they found the people on real drug did seem to start getting worse again, but it was at half the rate that would have been predicted from the natural history study. And we just heard that getting involved in natural history studies is important in designing and interpreting drug trials like this. So without that natural history data, they couldn't have shown the FDA that there was even a longer-term effect, a longer-term disease-modifying effect, which I think helped push this drug over the finish line. There is one approved drug for ataxia in Japan, taltirolin. It's marketed under the trade name Seradist. It's a thyrotropin-releasing hormone, which is a hormone that our brain releases to control our thyroid gland. And the releasing hormone is felt to have neuroprotective, anti-aging effects. And when it was tried in Japan, this was over 15 years ago, was found to be helpful for symptoms of ataxia. Interesting. And it was a subject of discussion with one of the first meetings we had of the North American Ataxia Research Group. It was the month after 9/11, and we met in Manhattan. And it was a very productive meeting for two reasons. We established in the first half of the meeting that the people in Japan had an interesting drug, should we get involved? A lot of discussion about that went nowhere. And then the second half of the meeting, Dr. Dave Lynch at Children's Hospital of Philadelphia stood up and said, we need a natural history study for Friedreich's. We're never going to be able to design effective drug trials without knowing how the disease behaves. And the next year, he launched the Friedreich's Ataxia Clinical Outcome Measures Natural History Study. So there's discussion is good, action is potentially somewhat better. Seradist, or taltirolin, can be obtained in Japan, but it has to be from a doctor who's licensed to practice in Japan, and they only give enough to get you from visit to visit. So I've got a couple of patients who are getting it. They happen to have, family in Japan. They travel there regularly. They pick up their prescription. They come back to the U.S. So, we now have two drugs. We have omeprazole, Skyclarys, and we have Seradist, which is a little less available. This is the spinocerebellar ataxia pipeline put together by Dr. Moore, who has spoken with us. This is just a brief outline of some of the companies that have drugs in the pipeline that are already in human trials. The Biohaven group is the top line. They're in the middle of a phase 3 trial, which they're putting together their data for presentation to the FDA, hopefully this year. We have a couple of stem cell groups that are active in China and Taiwan, doing scientifically very valid research. We have some gene blockers. The Vico company has a gene blocker. that can prevent the bad gene from making the bad protein in the spinocerebellar ataxias. We have a protein-busting drug from Selos, that's the trehalose study, which even after the bad protein is produced and is clumping up in nerves, infusion of trehalose seems to be able to break it up. So there have been some creative approaches that have made it into human trials in spinocerebellar ataxia, and there are many more in the pipeline. Dr. Moore has a much more extensive pipeline on the NAF website, which shows for each of the common genetic ataxias who's doing the research, what trials are going on, and potentially how to be in touch with those groups. Troriluzole is the biohaven drug. It's what's known as a prodrug of regular riluzole. Regular riluzole was approved for Lou Gehrig's disease a number of years ago as a neuroprotective agent. It would slow the progression of ALS. It was tried in Europe, regular riluzole, in ataxia, a short trial of 8 weeks and a longer trial of a year, and was felt to show benefits for ataxia and potentially slow progression of ataxia as well. So the company decided they should, the group from Yale originally wanted to get riluzole approved for ataxia, not just ALS. The company was not interested in doing that. So they developed a prodrug which turns into riluzole in your system and then has the same benefits of regular riluzole. It just bypasses the liver, so the liver doesn't chew up half of the dose. It seems to be easier to take once a day as opposed to twice a day with regular riluzole. And they're, like I say, finishing up what will hopefully be their definitive study for presentation to the FDA. There are 2 drugs that are recognized by the American Academy of Neurology as appropriate for off-label use in ataxia. One is regular riluzole, based on the 2 European studies, and the other is 4-aminopyridine, also known as dalfampridine, or under its marketed name Ampyra, where, again, it was initially approved for multiple sclerosis, for walking in multiple sclerosis, but it had a long history of use prior to that for other ataxic disorders, imbalance, episodic ataxia, dizziness, and people were getting dalfampridine from compounding pharmacies. They could mix it up for you and you would take it. Finally, it made it through the research pathway for FDA approval for MS, but not for ataxia. So while it was branded as Ampyra, if you had ataxia and you couldn't convince your insurance company by fibbing that you had multiple sclerosis, you really didn't have access to it from your insured benefits. But the compounding pharmacists continued to make it up, and many patients continued to try it and did get some benefits. Now Ampyra is available generically, and with the good RX coupons we can get online for both riluzole and dalfampridine, you can get it from many community pharmacies for less than $50 per month. So it's not super cheap. It's not like $10, but at least it's now more widely available for people to try under a doctor's supervision. So regular riluzole, 50 milligrams every 12 hours on an empty stomach, monitor your liver tests. The studies are still going on with regular riluzole, and a more recent study in France on ataxia type 2 thought maybe it didn't work as well with ataxia type 2. But it still is something that I will turn to if I'm looking for a symptomatic medication for balance in somebody whose balance is declining. Riluzole does have side effects. The most prominent side effect is dizziness. So if you're already dizzy with your ataxia, this might not be the best choice for you to try. Now, 4-aminopyridine or dalfampridine, good supporting studies for their use in ataxia, people with nystagmus, Again, even as a generic, the cost can be quite high, but with a coupon, you can get the cost greatly reduced, and you can still get it from compounding pharmacies. So the difference is the prescription formulation is 10 milligrams time release, taken twice a day, while the compounded formulation is 5 milligrams immediate release, taken 3 times per day. And some people feel one works better than the other. So about the only risk with this is taking a very high dose, over 20 milligrams per day, where there's an increased risk of seizures. Now, other symptoms can complicate ataxia. That there are many people with ataxia who have, the gait problem, changes in speech, changes in eye coordination, but they may also have stiffness or rigidity or spasticity or peripheral nerve numbness or other symptoms that complicate the underlying ataxia caused by the same genetic factor or the same acquired factor. And sometimes management of these non-ataxic symptoms can also improve mobility and quality of life. So fatigue is a very common non-cerebellar symptom, although there's some thought that there's a cerebellar pathway that mediates it. And sometimes, fatigue, which is so common in all the ataxic disorders, is caused by something other than the ataxia. It's caused by underlying medical problem or a sleep disorder. Some medications that you may be taking can have fatigue as a side effect. Depression can lower your energy levels and present as fatigue or apathy. Deconditioning, if you're not exercising because your favorite exercise is too hard to do, you can become deconditioned, which leads to fatigue, and you need to seek out exercise that you can do. Some of the energizing vitamins and supplements and herbs, stimulant prescription drugs, Ritalin, have been used when the fatigue is truly limiting. But remember, there could be unexpected side effects of even a natural herb. They can sometimes target your liver and can cause liver problems or kidney problems. And they may interact with other drugs that you're on. So if you are taking an herbal or nutritional supplement, make sure your doctor knows about it so it won't interact with something that he or she might prescribe. Now, this is one of the fact sheets on the NAF website about symptomatic management of these other symptoms and the variety of things that are available to help with muscle strength, muscle pain, muscle stiffness, the list goes on, tremor, episodic changes. You have good days and bad days. Can you even them out some way by taking a medication? So I made a spreadsheet for my patients, a checklist of off-label medications for ataxia. Things you can use for balance and coordination that have some literature. Maybe it was a small study of 10 patients in Brazil, but something to document a potential benefit. Many drugs for action tremor. And if you're seeing a movement disorders specialist as opposed to an ataxia specialist or a neurogenetics specialist, they're very knowledgeable about medications for tremor. Dizziness, vertigo, nystagmus that come from a part of the cerebellum that controls inner ear signals. There are, again, a number of, 2 columns of medications that have publications about their usefulness in suppressing and balancing out those symptoms. Now, if you read the fine print on any drug, it's going to, potentially cause GI upset, it's going to cause dizziness, it's going to cause fatigue. So the fine print can sometimes make you not willing to really try something for a more prominent symptom. But, it's a good discussion to have with your doctor. So for antioxidants, if you went online and typed in treatment ataxia, you're going to get, hundreds of thousands of hits. Everybody's got an idea. Some of them are valid science. Some of them are, just, things that have made it into the internet literature. Antioxidants, if you're choosing an antioxidant as an anti-aging, neuroprotective, something that will help stabilize you, There are some that are at the top of the list and some that may not have the impact we want. So the ones at the top of the list are kind of the ones I've listed here. They have the most literature behind them. They've been tried in people with a variety of neurologic conditions. So if you want to try an antioxidant supplement, I would say try one at a time, stay on it for 6 to 12 weeks, see how you feel. If it's not doing anything, think about changing it up, but always make sure your doctor knows what you're doing. And then for the immune therapies, if a bad antibody has been found, besides the gluten antibodies, which are treated with a gluten-free diet, there are a number of publications about immune-blocking therapies that can get rid of the bad antibody and potentially improve cerebellar health and function. So what about diet? These are slides from an NAF webinar presentation, and I think you can find them online. But I thought I'd review some of the things that have come up about diet. So over 25 years ago, the nutritionist working with me at the time and I put out this book, Nutrition and the Patient with Progressive CNS Disease, looking at general nutrition, micronutrients, appropriate use of vitamins, potential dietary changes that might help the cerebellum. And at that time, that was a stretch because we didn't even have genetic factors that were known at the time. So the key features of the ataxia diet that seem to hold true just in feedback from patients: elimination of refined flour and sugar products, so use complex carbs instead. Elimination of processed meats. Obtain fat from lean meat, poultry, low-fat dairy products. No skipping meals. Benefits that could indirectly help ataxia with proper attention to diet: weight loss, you tend to move better when you're thinner, reduced fatigue, improved bowel function, and better mood. And the NAF does have a fact sheet about nutrition and ataxia. So there is no dietary cure for regular ataxia, although for some of the inborn errors of metabolism, diet changes can help a workaround for a problem in metabolism that is probably genetically mediated. So these are the inborn errors that can be treated, and this is a diagnosis that you would make with your child's pediatrician, pediatric neurologist, your own neurologist, whoever is affected. Once the diagnosis has been made, there are diets and supplements that can help. Acquired causes of ataxia that can be treated with diet or supplements. Well, we talked about gluten ataxia. We talked about vitamin deficiencies. So that it's worthwhile, if you're thinking of starting a supplement to boost B12, find out what your B12 levels are before you start it, because you can overdose. You can get too much of a good thing. And megadoses of vitamin E, megadoses of other vitamins, can actually harm the nervous system. So you're going to want to discuss either with your doctor or with a nutritionist, proper amounts of supplements to take. Aging, many genetic and some non-genetic ataxic disorders don't present until adulthood. And it may be that aging pathways, natural aging, which we currently have to accept as something that we must live with, takes away reserve. And as you get older, you have less reserve to make up for a genetic problem or an ongoing nutritional or acquired issue. So much of the anti-aging literature, I think, can be transposed to progressive ataxia. Anti-aging diets, again, you get over 1 million hits, all different kinds of things, and I kind of listed a bunch of them there. But so which ones work, which ones are snake oil? There are risks in trying out a popular diet for weight loss, aging, or other aims. They promise too much. They set unrealistic goals. They cost too much. Because they often cut out key foods, popular diets may lead to dehydration, weakness and fatigue, nausea, headaches, constipation, and inadequate intake of micronutrients, vitamins, and minerals. So you should consult with a knowledgeable dietitian, and a 6 to 12-week trial on any dietary intervention is reasonable. You have to be an educated consumer. So the gluten-free diet, tricky because, gluten seems to crop up in many of the products that we buy. Read labels. If you go completely gluten-free, you might become deficient in B vitamins, calcium, and iron, so be aware of that. The Wall anti-inflammatory diet is another one that was first proposed for multiple sclerosis, where the primary mechanism is the immune-mediated problem. And this is a version of the Paleolithic diet, or the paleo diet, which says we should eat like our remote ancestors did. So there are foods that are acceptable on the Wall's diet and things that you should be avoiding. Intermittent fasting, where you'll fast for 16 hours and then have an 8-hour period where you'll take in your normal nutritional, whether it's a more restrictive diet or a more general diet. And intermittent fasting can produce ketosis, can also produce weight loss. And ketosis, where you're building up ketone bodies, has been used in childhood drug-resistant epilepsy and certain metabolic conditions, but its benefits specifically for ataxia I don't think has been fully demonstrated. And the little circles on the bottom are just comparisons of the components of classic ketogenic diet, where you're really aiming to get ketone bodies, the modified Atkins diet, medium chain triglyceride diet, and the typical diet. And what the intermittent fasting regimen might do to try to reproduce those. Mitochondrial diet, we've talked about mitochondria being very sensitive to genetic stress and non-genetic stress. So, there's been some work done on the mitochondrial diet, which is basically a ketogenic diet. You're trying to get the mitochondria to burn ketone bodies as opposed to their normal source of energy. A lot of research is going on. We tried a ketogenic diet a number of years ago in some of our patients with Friedreich's ataxia to try to turn the mitochondria in the brain into ketone burning agents. Didn't seem to work in adults, and they all got hypoglycemic and did not feel well on it. So again, worth discussion, but not jumping into it. So who should take vitamins? People over 50 should take certain vitamins. The frail elderly might benefit from a low-dose multivitamin. Women of childbearing age, children, may have certain vitamins that are becoming part of the standard of care. But you want to avoid megadosing on vitamins, which have potentially been found to be harmful. Then weight loss, unintentional weight loss is a concern. Restrictive dieting can cause weight loss, which could be a concern. Potentially getting to your ideal body weight, but you don't want to get below that. So, definitely monitoring your weight as part of your treatment plan is important. And these are some useful websites for patients and practitioners to access. The OMIM website was referred to. That's the Online Mendelian Inheritance in Man. Tremendous for tracking down details of certain genetic disorders. A genetic testing registry, where do you find a genetic test? And then, the National Ataxia Foundation and Friedreich's Ataxia Research Alliance websites, which have a lot of very good practical information about all of these topics. This is my team, and thank you very much. And we didn't run over.
All right, thank you, Dr. Perlman.
Thank you very much, Dr. Perlman.
Just a couple of housekeeping things before we let you head off to our next round of Birds of a Feathers. First of all, Bill, thank you for being with us today. Thank you for engaging with us and sharing your story. Thank you very much.
We also want to welcome our ataxia clinical trainees. Can I see by a show of hands, where are you located? Are you in the room? They're not in the room, but they're going to be joining this afternoon's Birds of a Feather session, so we want to give a special welcome to them.
All right. Joe Fry, is Joe Fry here? There he is. Joe, we got to connect after this. We got to take care of a few things because Minnesota Wild beat his Denver or Colorado Avalanche the other day, and we got to square up on some things, so I've got to know where you are. There we go. Is it selfie time?
It's selfie time.
Hey, we're going to get a nice big selfie for this conference. So Dana's going to set this up, and we're just going to want everybody to give us a nice big wave here as soon as Dana makes the call, all right?
Yeah, so Joel and I are going to come back here a little bit, and I'm going to be scanning the room, but we're going to put this on the website afterwards, and I think that it's just a really great opportunity for us to say, hey, look, we were here.
Everybody look at the lens. That's it. All right, everybody wave now.
Everybody wave.
There we go.
That's terrific. And
All right.
I'm going back one more time, Joel. I'm sorry, because
it's
I don't
okay.
think I was too even on that. All right.
There we go. All right.
Thanks so much.
Thanks so much. We'll see you tonight at the meet and greet at 5 o'clock right here. Birds of a Feather start at 3. 3
Yeah,
o'clock.
they start at 3 o'clock. Please
All
look
right.
at your program. On page 9, I believe, is the schedule for the Birds of a Feather.
All right. See you this evening.